Welcome back. This is pharmacology. We're going to talk about pharmacokinetics, pharmacodynamics, NSAIDs, opioids. Now, in learning pharmacology, you need to know 1, the name of the drug, 2, class, where does it belong, 3, mechanism of action, how does it initiate an effect on the receptors, last but not the least, side effects. Common side effects. As long as you know those 4, you're gonna be all set. So, pharmacokinetics is concerned with your drug absorption, distribution, metabolism, and excretion. So don't forget, lipophilic drugs, they can just go into the cell membrane. The hydrophilic drug, it needs a transporter. They need a facilitated transport. They need proteins to transport them inside the cell. Amphiphilic drugs are very unique because they're both lipophilic and hydrophilic. Example, your local anesthetics, your lidocaine. Okay. Don't forget that in absorbing the drug, if it's oral, it goes through the GI tract via the liver. So it undergoes first pass effect, right? And don't forget the meaning of bioavailability, which is the rate of concentration at which the drug appears in circulation. What's the formula? Area under the curve. So if it's AUC oral divided by AUC IV times 100, that's your bioavailability. What's the difference? Look at the graph. Between zero order elimination and first order elimination, both abscissa of the graph represents time and both ordinate represents drug concentration in plasma. Now tell me, how can we differentiate zero order elimination from first order elimination?
First order clearance is constant.
Go ahead.
So I guess first order has like a constant half-life, and the amount that like goes will be half of the original concentration. Whereas with zero order, there's just the same amount is being lost.
Okay, good. So when you think about zero order, always think constant amount of drug eliminated per unit of time, while first order elimination is constant fraction of a drug eliminated per unit of time. High yield for zero order elimination. Give me the examples of drugs that undergo zero order eliminations. The P.
Phenytoin, ethanol, and aspirin.
Excellent. So phenytoin, ethanol, and aspirin. So a P is round and they shape like zero in zero order. Okay, so P is like round, so zero order. First order elimination is flow dependent, right? In zero order, the half-life, it decreases with decreasing concentration. In first order, the half-life remains constant with decreasing concentration. Okay, good job. So we talk about distribution in pharmacology, volume of distribution, VD. Do I need to know the formula? Yes, this is like term 1 stuff. You already know this one. Increase in VD, where does the drug go? In the plasma or in this fat? Where do you think it goes? Increase in VD? Fat, so lipophilic, right? They go into the fat cells. If it's decrease in VD, it stays in the plasma. Okay. Don't forget that the drugs, they bind to albumin. They bind to plasma proteins. And some drugs, specifically inhaled anesthetics, they undergo redistribution. Types of drug kinetics, biotransformation. Zero order, first order, we'll talk about that. Phases of biotransformation, phase 1 and phase 2. In phase 2 is always conjugation, glucuronidation, all of those good stuff, right? Sulfonation, you put sulfide groups in there. Think about phase 2. Phase 1 is always oxidation via cytochrome P450. Okay, so phase 1 is the simple things like oxidation. Phase 2, much complex thing happens. Glucuronidation, you add glucuronic acid. You have acetylation, you add acetyl group. Sulfonation, you add sulfates in there, right? What's the significance of this, of biotransformation? Detox, right? So the drug is inactivated and modified into a hydrophilic metabolite and allows the drug to be excreted in the kidneys or in bile. For example, if I have an overdose of aspirin, how am I going to excrete that drug? It is excreted via renal, right? So what are you going to give me? If it's aspirin, what are you going to give me? So that I can excrete the drug renally via urine.
Bicarb.
Excellent. Your sodium bicarb. You always alkalinize the urine if I have an overdose in acidic drugs. For example, aspirin. How about if I have basic drugs? What am I going to do with the urine to excrete it? For example, I overdose in tricyclics, antidepressants.
Wouldn't you like acidify the urine?
Exactly. So you need to acidify the urine. So these are just basic, guys, from term 1. Okay. So don't forget, if it's a weak acid, you need to treat with sodium bicarb to alkalinize the urine. If you overdose, for example, in aspirin, methotrexate, or phenobarbital. If you overdose, for example, with TCA or amphetamines, these are weak bases, you need to treat the overdose with ammonium chloride to acidify the urine. Good job. Half-life, what's the formula for half-life? 0.7 times 0.7 times
VD divided by CL.
Excellent. Remember, 4 half-lives to completely eliminate the drug, and 4 half-lives to completely attain a desired concentration of a drug if it's first order. Okay? Don't forget that. 4 half-lives to eliminate the drug, 4 half-lives to attain the specified concentration of a drug. Most drugs are eliminated renally. That's why we talked about weak acids and weak bases. Some of the drugs are eliminated biliary, right? And some are eliminated via your pulmonary system, your lungs. For example, your inhaled anesthetics. Now, high yield loading dose versus maintenance dose. What's the difference? Loading dose, it depends on VD. Loading dose depends on VD, your volume of distribution, okay? Not venereal disease. Loading dose, VD. Maintenance dose depends on clearance, your CL. Is that significant? Is that significant? The loading dose depends on VD and maintenance dose on CL. And how is it significant?
I mean, I guess because with loading dose, you want to reach to your target concentration quickly, so you need to know the VD to know if it will be in the plasma or if it's because it will vary the dosage.
Excellent.
Whereas with maintenance dose, like you want to maintain it so you don't want it to clear out too quickly, so it would be either less in the body or more.
Excellent. So think about clinically. Think about a patient that has renal failure, chronic renal failure. What happens to the loading dose? Does it stay the same? Or do you increase or do you decrease the dose? Think about it. Careful. Loading dose stays the same. Okay. However, look at the maintenance dose. What do you need to do with the maintenance dose? You lower it down because it depends on clearance. Okay, so if someone has chronic renal failure, for example, the loading dose stays the same because it only depends on VD. However, maintenance dose, you lower it. Why? Because it depends on clearance. And you need to know the formula. Yes, you need to know the formula. That's a high yield point. Pharmacodynamics, types of receptors. Yeah, cell membrane interaction with enzymes and with DNA. We talk about drug receptor interactions, drug affinity, efficacy. Affinity is tendency of a drug to bind to the receptor. Efficacy, if it activates a receptor and triggers a cell response. So this is a good slide. Put a star here. Look at this one. Look at competitive antagonist. So what happens with the x-axis? Look at the abscissa, the x-axis. It's about the agonist dose. And the ordinate, we're talking about the effect, right? So look at the left. The first image here on the left, you have agonist only and agonist plus competitive antagonist. So does the competitive antagonist bind to the same receptor, to the active site?
Yes.
Yes, it binds to the active site. So what happens now to your EC50? Does it increase or decrease?
Wouldn't it decrease?
Look at the graph.
Ooh.
Look at the
It
graph.
would increase.
It would increase, exactly. Increase in EC50, meaning you decrease the potency. Okay, so let's look at the graph. Effect of competitive antagonist, right? So you are increasing the EC50, thereby you are lowering the potency. Okay, competitive antagonist, they are competing on the same active site as the agonist, thereby increasing the EC50, thereby decreasing the potency of the drug. Let's look at the next one. You have agonist only and agonist plus non-competitive antagonist. Does it bind to the active site or somewhere else?
Somewhere else.
Somewhere, where?
Like another receptor on.
Remember from term one, allosteric?
Yeah.
The allosteric site. Let's look at the graph. So what happens? You are lowering the efficacy, okay? The potency, it stays the same. The efficacy, you are lowering the efficacy, okay? Now, let's look at partial agonist. Does it bind to the same site as the agonist? To the active site? Yes, it binds to the active site. Now, let's look at the image here. How are we going to compare and contrast partial agonist with agonist? What happens to EC50? Which has a lower EC50? It looks like the partial agonist has a lower EC50. So the lower the EC50, the higher the potency, the lesser the drug is needed to administer in order to get a desired effect. High yield. The lower the EC50, the higher the potency, and the lower the drug needed to administer in order to elicit a certain effect. Okay? Look at this. However, look at the efficacy. It is lowered. So be careful when you have partial agonist. Okay? Be careful when administering partial agonist. Some of them has intrinsic sympathomimetic activity, which actually can worsen the symptoms. Okay, this is high yield, put a star on this slide. This is another thing about what's this? Potency that we talked about. This is competitive antagonism. We talk about agonist, antagonist, partial, inverse agonist, right? They bind to the same receptor but not to the active site. There is a response but opposite to the agonistic response. And you have some allosteric regulation there. Again, relative efficacy here. Look at the Y value, right? I have a decrease in my Y value. Let's compare the Vmax of drug A to drug B. I have a decrease in my Y value from 100%. We are now at 50%. I'm decreasing the Vmax. Therefore, I'm decreasing the efficacy of the drug. So based on this graph, which is more effective, drug A or drug B? Based on this graph, which one is more effective? Drug A or
Drug A.
Drug A. Look at the potency graph here. Which one is more potent, drug A or drug B?
A.
Drug A, exactly. The closer I am to zero, right, to the x-axis, I'm shifting to the left, right, from drug B to drug A. I'm shifting to the left. I decrease the EC50. I increase the potency, and therefore I decrease the drug needed to elicit an effect. Don't forget that potency is unrelated to efficacy, okay? And for efficacy, partial agonists, they have less efficacy than your full agonist. Again, this is your therapeutic index. Do I need to know the formula? Yes, right? What's the formula for your therapeutic index? Your tide, right? Don't forget TD50 divided by ED50, right? Tite, TITE, that's a mnemonic. Therapeutic index equals TD50 divided by ED50. Tite, TITE. Talk about potency, lethal dose, right? If it's lethal in 50% of the population, and we talk about therapeutic index, don't forget high yield, the drugs that has narrow therapeutic index, lithium, theophylline, warfarin, digoxin, and your anti-epileptic drugs. Tolerance and tachyphylaxis. High yield here is tachyphylaxis, meaning this is responsible for a decreased effect of a drug. If you keep on giving a drug, it depletes the body's endogenous mediators. It downregulates the receptors. So if you keep giving the same drugs, the body can develop drug tolerance, and eventually, in the end, you can have tachyphylaxis. Remember, this cannot be overcome by increasing the drug dose. Okay? So this includes nitrates, ephedrine, phenylephrine, niacin, LSD, and your MDMA. Pharmacogenetics, do I need to know the polymorphism, the different polymorphisms? Yes. N-acetyltransferase, isoniazid, that's high yield, sulfasalazine, and hydralazine. Okay, isoniazid for TB, hydralazine for hypertension. It can also give you lupus for your hydralazine. Of course, pseudocholinesterase is important for breakdown of succinylcholine. TMTP is important in breakdown of azathioprine. Some drug interactions, cytochrome P450, I think it's not specific. They're gonna, but you need to know the specific family, if it's CYP1, CYP2, or CYP3. Now we go to the meat of stuff, right? So your parasympathomimetics, M1, M2, M3. Remember, like I've said, from term 1, M1, think about CNS. M2, think about the heart. M3, think about the rest of the body. CNS, function, think about memory. In the heart, bradycardia. M3, this is parasympathetic, so increase peristalsis, increase contraction of the bladder, vasodilation of the blood vessels, and bronchoconstriction of the airways. Why? Because you need to increase the bronchial secretions. This is parasympathetic. Parasympathetic is rest and digest. Remember that you can also have some nicotinic receptors in the skeletal muscle, which increases the muscle contraction and tone. Let's go to the drugs. Okay. Direct parasympathomimetics and indirect parasympathomimetics. Direct, they bind directly to muscarinic or nicotinic receptors. Indirect, they inhibit acetylcholinesterase. So let's look at direct parasympathomimetics. Bethanical, it is used for neurogenic ileus and for urinary retention. Post-op, right? Patient, they cannot urinate. They have urinary retention. You give bethanical. Carbachol, it is for alleviation of intraocular pressure or miosis. Carbachol is special from the rest of your direct parasympathetics because they act on what receptor?
Muscarinic and nicotinic.
Excellent. So they act both muscarinic and nicotinic receptors. Where can you find nicotinic receptors?
Presynaptic.
Presynaptic, where else? Adrenal gland, right? Which is faster, nicotinic receptors or muscarinic receptors?
Nicotinic.
Why? Remember, they are ligand-gated channels, right? So we have influx of your sodium, calcium, potassium, chloride. Contrast this one with your muscarinic, right? Your muscarinic is G, S, GR, and GQ, right? I forgot M1, M2, M3, GQ for M1, GI for M2, Q for M3. So kick, right? Q, I, Q. Don't forget that one. And don't forget what happens to the intracellular receptors. If it's GS, increase cyclic AMP, increase protein kinase A, increase intracellular calcium. The opposite of that is GI. You have decreased cyclic AMP, decreased protein kinase A, and decreased intracellular calcium. GQ, you have that PIP2 is cleaved to IP3 and DAG, increase in protein kinase C, increase in intracellular calcium. So just basics from term 1. Pilocarpine. Pilocarpine is for glaucoma. How does it help in glaucoma? Specifically, your pilocarpine. What does it do?
Contracts the ciliary muscles.
And also remember it for how are we going to produce aqueous humor from term 2? Where does it come from?
Canal of Schwann.
The production of your aqueous humor, where does it come from?
Ciliary body.
Ciliary body. So both your ciliary muscles and your ciliary epithelium, right? And then it goes to where? Posterior chamber of the eye. Then it goes to where? Anterior chamber of the eye. And then it goes to, someone said it, canal of Schlemm. So that's the pathway of your aqueous humors. Anything that's blocking there, or there's a decrease in production, you can have glaucoma. Okay? So pilocarpine, it induces sweat, tears, and production of saliva. It is used for open angle and closed angle glaucoma. Another direct parasympathomimetic is methacholine, which is to diagnose bronchial asthma. So how are we going to do that? Via your bronchial challenge test. If I give you methacholine, what happens?
Bronchoconstriction.
Bronchoconstriction. Excellent. And then you just measure the amount of air that the patient can get, right? So that's your methacholine challenge. Remember, it induces bronchoconstriction. That's it. Let's talk about your parasympathomimetic, your indirect. So this is to inhibit acetylcholinesterase. How are we going to diagnose myasthenia gravis, edrophonium? What is myasthenia gravis? You have autoantibodies against what?
The neuromuscular junction.
Autoantibodies against specifically what? Your postsynaptic acetylcholine receptors. Okay, so you have autoantibodies that's actually competing with your acetylcholine and binding to those receptors. Okay, that's the pathology behind myasthenia gravis. So how am I going to diagnose this? By giving edrophonium. Now, tell me the difference in the reaction of a patient. If the patient is in myasthenic crisis versus cholinergic crisis, I give edrophonium. How do I know that the patient is in myasthenic crisis?
If it's myasthenic crisis, then you'll see a transient increase in muscle strength.
Excellent. Very good. So you have a
positive
transient.
Tensilin test.
Exactly. So that's your Tensilin test. So you have a temporary improvement of symptoms. However, if the symptom worsens, you have cholinergic crisis, meaning the patient has an overdose with his drugs, with his indirect parasympathomimetic drugs, right? So that's your Tensilin test. That's your edrophonium. That's high yield. How am I going to treat myasthenia gravis? Pyridostigmine, get rid of myasthenia gravis. Pyridostigmine. How am I, if I have an overdose in anti-muscarinics? What do you think you should give me? It's physostigmine. So that's high yield for organophosphate poison. Physostigmine is antidote for your atropine overdose. If you overdose in anti-muscarinics. Neostigmine is also for myasthenia gravis. So for this one, when it ends in mean, like stigmine, think about myasthenia gravis. Okay, neostigmine, pyridostigmine, right? So stigmine, think about myasthenia gravis. Don't forget also that indirect parasympathomimetics can also be used for Alzheimer's. What are the three drugs? High yield donepezil, rivastigmine, and galantamine. Next, muscarinic antagonists. So they antagonize the normal reaction, right? So for example, M2, you antagonize M2, you increase the heart rate. You antagonize M3, you decrease gastrointestinal tract secretions, you decrease bladder contraction, you decrease bronchial secretions, you have mydriasis, dilation of the pupil. In the exocrine glands, you have decrease in secretions. Put a star here. This is a high yield slide. Now let's look at the drugs. What's the difference between a tertiary amine and a quaternary amine? The quaternary amine, you have it has a tetrahedral form, right, from organic chemistry. So if it is tetrahedral, so everything, you have an alkyl group everywhere, right? 4 bonds for this, therefore it cannot cross the CNS, or quaternary. Okay, so it has poor oral bioavailability and CNS. It doesn't cross the CNS. However, your tertiary, it's good. It's charged. It has a positive charge. So it can cross the CNS. You need to know the drug name, the effect, and indication. So the star of your muscarinic antagonist is atropine. What does it do? It's an antagonist, muscarinic antagonist. So it increases heart rate. You have mydriasis and you have cycloplegia. This is used as an antidote for anticholinesterase poisoning. Could you give me the signs and symptoms of someone who has organophosphate poisoning? What are the signs and symptoms? Dumbbells, diarrhea, urination, meiosis, bradycardia, bronchoconstriction, lacrimation, salivation, right? If in the vignette you have that, think organophosphate poisoning. What's the treatment? Think atropine. Scopolamine is used for motion sickness, right? Homatropin tropicamide used for cycloplegia, specifically in ophthalmology, right? To dilate, remember when you use your ophthalmoscope, which you're gonna learn next term, when you use this drug to dilate your uvea, right? For pupillary dilation to allow examination of the fundus. Benztropine, piperidine, and trihexyphenidyl, think anti-Parkinson's drugs. So you can also use muscarinic antagonist in Parkinson's disease, okay, to decrease what? Remember the extrapyramidal symptoms from Parkinson's, your tardive dyskinesia, your akathisia, right? Oxybutynin, tolterodine, solifenacin, dicyclomine. This is for overactive bladder incontinence, okay? Overactive bladder incontinence. Darifenacin, low yield. For quaternary amines, think ipratropium. This is high yield. Ipratropium for asthma because it can cause bronchodilation. This is used for COPD and bronchial asthma. So what are the side effects? Put a star here of your antimuscarinics. There's a lot. What I like is at the bottom here, blind as a bat, mad as a hatter, red as a beet, hot as a hair, dry as a bone, the bowel and bladder lose their tone, and the heart runs alone. You have mydriasis, delirium, flushing, hyperthermia, decreased secretions and dry skin. You have urinary retention and paralytic ileus, and you can have tachycardia. If you overdose in your anticholinergics, for example, your atropine, benztropine, trihexyphenidyl, or via your antidepressants or antihistamines, you have the signs and symptoms, right? So what's the treatment again? Isostigmine, okay? For anticholinergic overdose. So direct parasympathetic adverse effect is very local. Indirect parasympathetic, there's a lot, okay? It can induce bradycardia, hypotension, sweating, salivation, meiosis, weakness, paralysis, and of course, if you're using those myasthenia gravis drugs, it can induce cholinergic crisis, okay? So you give atropine and you give pralidoxime. Which should you give first, atropine or pralidoxime? Anyone?
Atropine
Atropine. Why?
for the CNS effects.
Excellent. So it goes to the CNS. However, it doesn't do something. It doesn't act on the?
Muscle weakness, the flaccid paralysis.
Yes. Why? Because it doesn't act on the nicotinic receptors. Okay? It doesn't act on the nicotinic receptors. And if the patient has some muscle weakness, you can give pralidoxime. Okay? However, in the vignette, if there's these two drugs are there and you're sure that the patient has organophosphate poisoning, always pick atropine. Why? Remember, pralidoxime can undergo aging, right? So always pick atropine. You give atropine first. However, it doesn't reverse muscle effects, so you give pralidoxime. Atropine crosses the CNS. Polydioxin only has peripheral effects. Don't forget the dumbbells mnemonic, it's here, that's high yield. Okay, let's talk about direct sympathomimetics. We now have the sympathetic nervous system here. So this is fight or flight. So remember your KISS, QISS, alpha 1, alpha 2, beta 1, and beta 2. Albuterol, salmeterol, terbutaline, this is for acute asthma for bronchodilation. Clonidine, hypertension. Dobutamine, heart failure, right? And cardiac stress testing for dobutamine. Dopamine, heart failure. Epinephrine for anaphylaxis, cardiac arrest. Phenoldiazepam for hypertensive crisis. Isoproterenol for bradycardia or heart block. Methyldopa for hypertension. Norepinephrine for shock. And phenylephrine for hypotension, rhinitis. Okay, so for this one, know the drugs, know the receptors, and know the indications. Now, this is a high yield slide. So if I give norepinephrine, remember, norepinephrine preferentially binds to your alpha receptors, right? So if I give norepinephrine, what happens to my peripheral resistance? I increase the peripheral resistance, and I have a reflex bradycardia. For epinephrine, it acts both alpha and beta receptors. So if I give epinephrine, I decrease the peripheral resistance slightly, right? However, I have a reflex tachycardia for my heart rate. For isoproterenol, it binds to the beta receptors more. So what happens to the peripheral resistance? If I give isoproterenol, it decreases. Then I have a rebound effect with the heart rate. I have a reflex tachycardia. So this slide is high yield. They're gonna give you tracings. They're gonna give you tracings of the SBP, DBP, diastolic blood pressure, and the mean arterial pressure. So the blue line here is your systolic blood pressure. The green line here is your diastolic blood pressure. And the yellow line here is your mean arterial pressure. Look at norepinephrine, right? We are increasing the systolic and the mean arterial pressure, right? Why? Because you're increasing your peripheral resistance. You have an unopposed alpha 1. So what happens to the heart rate? You have a reflex bradycardia. Let's look at epinephrine here. You are increasing what? You are increasing also again, this is SBP, systolic blood pressure. You are increasing the mean arterial pressure. However, look at DBP. It is decreased, right? So the peripheral resistance is decreased. Therefore, you can have increase in heart rate. Let's look at isoproterenol. Isoproterenol, you have increasing in SBP. The mean arterial pressure is slightly decreased, and the diastolic blood pressure is decreased, right? So for this one, what happens to the peripheral resistance? It is decreased, right? Your MAP is decreased and your DBP is decreased. Both of them are decreased. So you have unopposed beta 2, you have a decrease in peripheral resistance. Therefore, you have a reflex tachycardia. The cardiac tracings are high yield for your exam and also for the step 1.
Hey, Nick, I have a question about that real quick. For the epinephrine, is that more for lower doses of epinephrine that you would have the increase in heart rate?
Yes. I think for higher, remember the higher effects of epinephrine, you activate the alpha more, right? Here, this is a lower dose of epinephrine because of the beta effects, right? Don't forget epinephrine, more epinephrine, higher dose is alpha, lower dose is beta, okay? Just to clarify, the epinephrine here is beta, so it's a low dose epinephrine. Is that okay?
Yeah, thank you.
All right, good job. So this is high yield. The tracings are high yield. Next, indirect sympathomimetics. These are they increase the activity of your catecholamines by what? Inhibiting reuptake, okay? So look, 3 important high yield indirect sympathomimetics, amphetamines, right? Reuptake inhibitor, indirect general agonist, and it releases catecholamines. Used for what? ADHD, narcolepsy, obesity. Cocaine, yes, reuptake inhibitor, right? Indirect general agonist also. It is used for local anesthesia and for vasoconstriction. Ephedrine, it is both, it releases catecholamine and indirect general agonist. It is commonly used for a nasal decongestant, but now they use pseudoephedrine because you can modify the ephedrine and make it into a much more lethal drug. So when you think indirect sympathomimetic, think they either increase the activity of endogenous catecholamines on the synaptic cleft, or they increase the release of these catecholamines, or they inhibit reuptake of the catecholamines. Okay? Know the indications for each. Okay, do I need to know this one? The receptor and the sympatho. What's the effect for each? I think, yeah, it's high yield. So let's go over alpha 1. So what happens if I have activation of my alpha 1? I can have mydriasis, I can have vasodilation, increase in preload, I can have increase in glycogenolysis, okay, or for the male reproductive system, remember, shoot, I can have ejaculation from the vas deferens. For alpha 2, this is GI, decreased aqueous humor, increased platelet aggregation, decreased insulin release for alpha 2, don't forget that, or decrease in lipolysis. Beta 1, one heart, don't forget about the heart. It's sympathetic, so I am increasing the heart rate. I'm also increasing renin. Beta 2, 2 lungs. So think about bronchodilation. Think about increasing insulin release. Think about increasing lipolysis. Think about increasing aqueous humor production. Okay? So for pharmacology, I think watch Sketchy Farm. Okay? Watch Sketchy Farm. It's very good. We talk about alpha 1 agonist, alpha 2, beta 1, beta 2. Know the side effects. Basically, alpha 1 agonists, you can have hypertension. For alpha 2, you can have respiratory depression, right? Bradycardia, meiosis. For beta 1 agonist, tachycardia and arrhythmias. For beta 2 agonists, you can have tremors. That's the most common side effect for beta 2 agonists. For the indirect sympathomimetics, this is from term 2. Don't forget about intoxications of amphetamines, cocaine, and your ephedrines. Let's talk about blockers. So alpha blocker, you block alpha 1, therefore you have decrease in vasoconstriction, you decrease in blood pressure. Beta blockers, if it's propranolol, non-selective, both beta 1 and beta 2, be careful in administering non-selective beta blockers in asthma because it can cause bronchoconstriction. Also careful in diabetics. Why? Because it can inhibit insulin release. It can also mask signs of hypoglycemia in a diabetic patient. So be careful with non-selective beta blockers. Alpha 2 adrenergic agonist. You have, this is GI. So for this one, I decrease the sympathetic tone, I decrease the vasoconstriction, and I decrease my blood pressure. So for monoamine depleting agents, you have your reserpine. This is not actually used right now. This is only used in the hospitals. So your reserpine, it inhibits your VMAT, which converts your dopamine to norepinephrine in your axon, in your presynaptic axon. That's your reserpine. Put a star here. if you block alpha blockers, they all end in osin. Okay, doxazosin, terazosin, they end in osin, osin, osin. Think about alpha blockers. What's the common side effect? Orthostatic hypotension. Don't forget, tamsulosin can be used for BPH, and your phenoxybenzamine for your pheochromocytoma. Phenoxybenzamine is an irreversible, right, inhibitor of your catecholamines. Contrast this one with phentolamine. Phentolamine is a reversible alpha blocker. So, for example, if you're having a surgery for pheochromocytoma, you give phenoxybenzamine first because it's an irreversible blocker. And then for symptomatic treatment, you give phentolamine. Phentolamine is also used in MAO inhibitors if you have hypertensive crisis in MAO. If the patient is taking a MAO inhibitor, phenozine, for example, and they forgot that they're on MAO inhibitor, they went to a restaurant and they ordered cheese, they ordered red wine, they're having hypertensive crisis, you can actually give phentolamine to reverse the alpha receptor activation. Next, alpha 2 adrenergic agonist, or GI. So they increase the GI. Clonidine, methyl dopa, those are the two things that much more high yield here. Okay, clonidine is for ADHD and hypertension, and methyl dopa is safe in pregnancy. Right. So what are the side effects? Think orthostatic hypotension is always there. Okay, because you're blocking alpha 2. So the effect is orthostatic hypotension. The rest, I think, is low yield. So alpha 2, antihypertensive, clonidine, methyl dopa. Methyl dopa, safe in pregnancy. Common side effect of both, orthostatic hypotension. We're good so far?
Yes.
Yes? Okay. So know the names, as I've said, know the names, the drug class, indication, right? Mechanism of action of each, and the side effects. Now, let's talk about analgesia, okay? Okay, I came into your office. I said, Doc, I have this pain. Give me some morphine. Would you give me some morphine, please? Of course not, right? So what is the first thing that you need to do before giving any drug? Before giving anything, what else do you need to do?
Well, for pain, you need to quantify it.
Okay, good. But before you give drugs, a treatment, give me a treatment.
BBC?
So non-pharmacologic first. Okay? If on the 1 to 10 scale, if you do the Wong-Baker scale, if it's like 1 or 2, less than 5, it's not that painful. So you do non-pharmacologic things first before you prescribe drugs. So if it's mild pain, now let's look at mild pain. What do I need to give first? Non-opioid analgesics. Okay, if it's a mild pain. This is according to the World Health Organization. Okay, so for mild pain, non-opioid analgesics. For moderate, you just add a mild opioid. For severe, you add another one, a strong opioid. Okay, instead of mild, you add strong. Okay, so first, the high yield point. If it's just like 1 or 2 in the pain scale, try non-pharmacologic first. It's a massage, chiropractor, something non-pharmacologic, okay? And then if it worsens, right, it's still there. Now it progresses to milder pain. You add non-opioid analgesics. That's the first line agent for mild to moderate pain, right? And then if for moderate pain, you just add a mild opioid. If it's severe, you add a strong opioid. So what is common in the 3 of them? You have a non-opioid analgesics. That's common. Then you just add an opioid. Okay, so remember, when you prescribe, when you're in the wards in the future, right? Next year, hopefully, when you're in the wards, do use the minimal effective dose. Okay, when you prescribe opioid, remember we have an epidemic that's going on, an opioid epidemic, right? So you use the minimal effective dose for the shortest duration of time. Okay, to minimize your adverse effect. Because what is the most common side effect of an opioid? Respiratory depression. So it depresses your respiration. It goes to your DRG in your pons. It represses that one. Remember your ventral respiratory group and your dorsal respiratory group in your pons. And then you can't breathe anymore. Okay? Okay, the drugs. Your oral analgesics. So we have non-opioid and opioid. Acetaminophen, NSAID, and selective COX-2 inhibitor. So acetaminophen, right, it is contraindicated in liver failure. So if the patient, in the vignette, if it says the patient has liver failure, right, and then the patient has a mild pain, don't ever pick acetaminophen. Why? Because it is contraindicated in liver failure. You cannot metabolize acetaminophen. Remember, it is broken down in the liver, right? What is that? If I overdose with acetaminophen, what are you going to give me? What's the treatment?
Acetylcysteine.
Excellent. N-acetylcysteine. So next, NSAIDs. NSAIDs. Aspirin, ibuprofen, right? Diclofenac, naproxen, indomethacin, meloxicam. So let's focus on NSAIDs. What's the pathway for your NSAIDs? Your arachidonic acid, right? Metabolite pathway. So first you have membrane phospholipids. From membrane phospholipid to what?